Dear colleagues, dear Dr. Witt, thank you for the invitation. It's a pleasure for me to be here and present our results with the emergency treatment of aortic rupture from chronic type B aortic dissection using the Candiplex. These are my disclosures. We all know that the treatment of aortic rupture from chronic type B aortic dissection is still challenging and associated with high perioperative mortality. The goal of our endovascular treatment is to prevent, as you already heard, the aortic hemorrhage. We have to do that by creating a seal at the proximal aortic dissection entry point and also not the last to induce thrombosis of the false lumen. We know that the thrombosis of the false lumen after TBAD of the chronic type B aortic dissection covering the proximal entry alone is achieved in 78% of the persons with whom the dissection is limited to the thoracic aorta, but only in 13% of the patients with more extensive dissection. That's why new endovascular strategies to abolish the false lumen backlog have been introduced. The most well-known, as you can see here, is the fenestrated and branch devices. They are CMD devices and not always suited in the thoracic aortic dissection. And furthermore, they need a production time of more than 8 weeks, which precludes them from using in acute cases. For the acute cases, iliac devices such as the occluders or different occluders, as you can see here, have been introduced. These devices are limited in the acute situations due to their small lumen and small size that cannot achieve acute thrombosis of the false lumen. Newly introduced of the market are the Candiplex. They can be homemade, as you can see here. It's up to your imagination to find a proper design. The disadvantages of this in acute setting is that you have to also occlude the central lumen of the devices, which is not always technically easy and feasible. Thus, you have more blood flow in the lumen. A very new generation of Candiplex, company manufactured, which is, in my opinion, very suitable for the treatment of acute ruptured chronic type B aortic dissection are the Candiplex. As you can see, the advantage is that they come in a tapered form, and also after removing the central introducer, their central lumen, they occlude immediately, causing thrombosis of the false lumen. I would like to show you how the Candiplex devices work in real plexes. I brought you the first our two cases. One first case, a 50-year-old female patient presented with Marfan syndrome with a post-type B aortic dissection aneurysm of the aortic arch and a thoracoabdominal aortic aneurysm of 66 millimeters in diameter. She had an aortic valve reconstruction and a replacement of the aortic arch in an elephant trunk technique sooner. But 4 days after the procedure of the open procedure, she presented in our hospital with a severe back pain. And you can appreciate here on the CT scan, the cause of the pain was a contained rupture of the proximal dissected descending aorta with a periaortic hematome. We put the patient on the angiosuit and we punctured the both common femoral arteries, and we introduced 2 large bore sheaths, and we cannulated both the true lumen and the false lumen. As you can see here, in one lumen, the true lumen, we also had a pictate catheter for angiography. And we performed an IVUS to confirm the position of our catheters in the respective lumina. You can see also on the right side of the angiography also the contrast media coming out of the perforation. The next step in our case was to perform a TVAR of the true lumen from the origin of the left subclavian artery down to celiac trunk. And the second was to place the Candiplex in the false lumen, retrieving the delivery system. As you can see here in the control angio, we have no more contrast go into the false lumen and acute perfused and a really expanded true lumen with a perfusion of the celiac artery. We could follow this patient for up to 6 months. As you can see here, we have the follow-up results with a stent graft in the true lumen, very nicely expanded, and the thrombosis of the false lumen with the Candiplex device. A very similar case is a 70-year-old male patient, arterial hypertension, obesity, comorbidities, who suffered 9 years ago with a bicuspid aortic valve replacement and ascending replacement, and 2 years after the previous operation and a non-complicated type B aortic dissection. He was admitted to our institution with a post-dissection thoracoabdominal aortic aneurysm 68 millimeter. A CMD was planned in this case, but the patient did not wait for the CMD. He presented with a massive back pain. You can appreciate here again the contained rupture, this time also of the false lumen, and with massive hematoma in the mediastinum. The same procedure, this time we did not have time for a general anesthesia, local anesthesia, both groin puncture, true lumen, false lumen cannulation after IVUS control, the same EVAR in the true lumen from the left side clavien down to the celiac, candy plug in the false lumen, vascular plug in the second false lumen in the left side clavien artery, and you can appreciate here the true lumen patent in the EVAR and the occluded false lumen due to the candy plaque. I can conclude saying you that the candy plaque device second generation in combination with TVAR to treat the contained false lumen rupture of chronic type B aortic dissection demonstrates good functional results immediately and during follow-up. Thank you for your attention.